Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. It is my great pleasure to have my good friend, Dr. John Linsalata, who's a board-certified orthopedist practicing on Staten Island and Brooklyn here. And we're going to talk about, we talked about a few weeks ago, issues that happen with the upper extremities, the shoulder, the elbow, the wrist. Tonight's show is going to be really dedicated to the legs. Ankles, knees, hips, things that we have replacements for, all kinds of things. And over years of being an athlete, degenerative changes, arthritic changes, we have replacements now. We've really come a very long way in the orthopedic field. So we're going to start really from scratch, and I wanted to say thank you to Dr. Linsalata. John, pleasure. Thank you as a good friend for coming here and teaching us a little bit. You've done the show before, and we've always run out of time doing all of orthopedics in one session. So it's hard to do, so we're just going to do the legs. Maybe just as an introduction, what's an orthopedic surgeon and what's their training? Sure.
An orthopedic surgeon is a specialist in musculoskeletal care, taking care of bone, muscle, tendon, ligament issues, and sometimes nerves. And there's a spectrum of specialties within it. Some do trauma, like fractures. Some specialize in treating soft tissue injuries, like in athletes, which is my subspecialty, sports medicine. Some who just do children, the pediatric orthopedics, some who do tumors in the bone, oncology. Some just do the foot and ankles, some the spine, some specialize in just the hand. So it's a whole subspecialty within the field. I tend to do general orthopedics and with a kind of a little bit of a subspecialization in sports. So I see a little bit of everything.
So tell us, when we talk about the legs, what are the more common injuries that you see?
Probably the most common, the most common injury where the people going to have surgery is probably in the knee. You see breakdown here, people getting meniscus tears and ligament injuries, ACL. We're going to talk words. ACL. ACL, I'm sorry.
Anterior cruciate ligament.
Yes, anterior cruciate ligament. You hear that a lot in athletes. Right. And unfortunately, it's a dreaded injury because it generally means it's a season-ending injury. And, 9-month recovery. So no one wants to hear they tore their ACL. But with the current techniques, people get back to playing at the same level they were before.
So there are many people who in the 1980s and 90s, famous athletes, Knicks, I think Bernard King,
yes,
his career came to an end because of that.
Yes.
What difference is now available that makes people be able to continue their career?
Sure. So I think a little bit we've refined techniques as far as what the tissue we use. So I think we generally try to use the person's own tendons as opposed to a cadaver tendon, which we know is better and stronger in a primary repair. We learned that Bernard King had what was called an IT band, a small fascial band on the outside of the leg used to make his ACL. We learned that really wasn't such a strong graft. Unfortunately, he paid the price for that. We know that using the patella tendon and the piece of the patella is more beneficial, or using a piece of the quadriceps tendon, or even hamstring tendons, are better options for athletes. I think the techniques have improved. We learned that it's important to put the actual implant exactly where the ACL naturally inserts to kind of better recreate the anatomy, so that the surgical techniques have been refined. And just as importantly, the rehab has been refined, getting people moving earlier. So they weren't so happy with the fixation that they had available back in the 80s, so they put people on a cast afterward for 4 weeks. They wouldn't move their leg, everything would atrophy, they'd be stiff, and then they'd be kind of playing catch up. Now people are moving day one. They start getting range of motion, they start working their quadricep muscles to try and prevent that atrophy. And actually we do prehab. Before surgery they're rehabbing to get their range of motion and get their strength back. Because we know that's important to kind of speed up their ultimate recovery.
So you brought up the knee, and we're going to stay on the knee for a little bit before we jump to the hip and the ankle. Tell us about people. It seems like everyone has a meniscal tear.
Yeah.
And what is the meniscus?
Yeah. The meniscus are the little fibrocartilages that sit between the bones. So we have the thigh bone, which is the femur. We have the leg bone, which is the tibia. In the front here, we see this is the patella here and the quadriceps coming in. We were talking about inserting through the patella tendon. Between the two bones, there's these little fibrous structures called menisci. There's one on the inside, the medial meniscus, one on the outside, the lateral meniscus.
Show it to the...
And they act actually as a little bit of a shock absorber, because the bone is hard, the meniscus is a little softer, so when you impact it, it can it can deform a little bit, give, and then rebound back to its normal position and take in some of that energy. It also helps to improve the contour of the bones, because the femur naturally is rounded, the tibia a little bit flat. The meniscus is meniscoid shaped, a little bit of wedge shaped, so it helps transmit the stresses from the femur onto the tibia more evenly, so you're distributing stress more evenly, less breakdown of the cartilage. So it's a very important structure for the normal function of the knee. With time, the meniscus gets a little bit more brittle and breaks down. And, the cartilage in the knee also breaks down. That's part of like early arthritis. That puts more pressure on the meniscus. So it's like kind of one affects the other. The meniscus breaks down, it puts more pressure on the cartilage. The cartilage breaks down, it puts more pressure on the meniscus. And then with time, the meniscus can go on to tear. So tears that occur without an injury, often referred to as degenerative tears. You typically see more middle-aged to older patients. Just walking, my knee started hurting. I didn't do anything. And those get those degenerative tears, very common. And a lot of those get better with just resting in them, anti-inflammatories, exercises to strengthen the muscles. Many of those don't need surgery. With just time, they can improve. You could also see traumatic tears that occur, in a younger athlete from a cutting maneuver or hyperflex position where their knee is twisted. You see it in wrestlers when they're down that knee bent position, they get torqued. In skiers when they twist their knee. So any athlete. Or especially associated with, when we talk about that anterior cruciate ligament tears, that the twisting maneuver that causes the ACL to tear also stresses the meniscus, and the meniscus tears. Those are a different type of tear. Those more commonly go on to need surgery. So when you have a piece of meniscus and it creates mechanical symptoms where it's catching or locking, you're more prone to go on to say, let's think about doing surgery for this to take away that mechanical irritation, particularly when there's not significant arthritis in the joint.
Tell us about the controversies of this. I mean, I'm even reading in my literature,
Yes.
you read most medical journals, there was a whole thing a few years ago that if you did the cartilage repair or the meniscal repair, you basically increase your risk of needing a replacement in the future or some other things.
Yes.
And it goes in fashion, out of fashion, in vogue, out of vogue. Tell us a little bit about it, because so many other people here have been either told by their orthopedist or thought about it, and they have knee pain, and the debate about whether to have these procedures, especially,
Absolutely.
maybe tell us a little bit how the surgery is done.
Yes. So first of all, there's different type of surgery. So meniscus, when you hear people say that, hey, I have my meniscus fixed, most of the time, probably 90% of the time, it's not quote unquote fixed. You're doing a meniscectomy, trimming the torn piece of the meniscus. So the surgery is done arthroscopically. We make two portals in the front of the knee, one in the front anterolateral, anteromedial. You go in, you look through one, and with fine instruments, you can go in and do surgery. For most meniscus tears, you're trimming the torn piece of the meniscus that's causing mechanical irritation of the joint. That's a meniscectomy. Most people you hear have meniscal surgery, that's what they're getting. You can also truly repair the meniscus. Certain patterns of tears can actually be stitched back. Those are wonderful because you can restore the normal function of the meniscus and prevent the potential development of arthritis later. The problem, most meniscus tears are not amenable to being fixed. The meniscus is like I said, a fibrocartilage. The blood circulation to the meniscus comes from that peripheral third of the meniscus. So the tear really that occurs in that peripheral third, you can stitch and expect it to heal. If the tear is really kind of running into the central part of the meniscus, it's like when I tell my patients, if you have like a little clip your fingernail and you put a piece of tape on it, but you don't expect the nail to heal. There's no blood in your nail. It cannot heal. Or a necrotic toe. You can't like, put some tape there and expect it to heal. There's no blood. So if you don't have circulation, it can't heal. So the majority of the meniscus, the inner 2/3, is not necessarily so repairable. It also depends on the pattern of the tear. So if you have a nice, like someone cuts their skin, you can put stitches in it and repair it. But if someone comes in who falls off their motorcycle and their skin is all kind of ripped apart, you can't stitch all those little pieces together. You just got to let the skin kind of regenerate or do a graft there. Well, same thing, if the meniscus is all ripped apart and degenerate, you can't stitch that back together. So majority of meniscus tears, you can't fix, you have to trim them. So if you have a type of tear that you can fix, that's a procedure that will restore the function of the meniscus and hopefully prevent the development of arthritis. The problem is that most people don't have that type of tear. And then, so people who have meniscal tears who have surgery, often go on to develop arthritis. I think that happens, I think whether they have surgery or not, because once the meniscus tears, you lose some of the natural function of the meniscus. I think if you do surgery and you go in there and take out too much meniscus, and it is a delicate surgery. You have to be careful to not damage the cartilage. Unfortunately, if it's not done well, you can damage cartilage too. So it has to be done technically in the right way also. So I think that there's no question that that the surgery can increase your risk of getting arthritis down the road if it's not done well. Mm-hmm. And I think that in my hands, I think what the current literature is telling us is that when someone has a meniscus tear, they all deserve an opportunity to get better on their own. Therapy, anti-inflammatory, time, and a lot of them will get better. If they don't, and they're having mechanical symptoms like something's catching, that's where I think the surgery can come in and actually be beneficial.
See, and I use the very high medical words. I just call it like an Oreo cookie with a lot of stuff in the middle. And it gets pushed out, and you can't put the white stuff back in no matter what. Yeah. That's what I sort of think about a lot of things in this medicine, especially with the meniscal tear. Yep. And once it goes out of place, it's out of place, and you can't just shove it back in. And that's
majority of that.
Tell us about knee replacements. I mean, this is becoming so commonplace right now. Everybody who comes into my office as a neurologist, when I look at their feet to see if they have any nerve damage, and I see more cuts on the knee than they could ever be imagined.
Sure.
And it's almost anyone over 70 who doesn't have one. You sort of look and say, I wonder why they didn't have their knee replaced.
Yes.
So tell us when it becomes necessary for someone to have their knee replaced.
So, knee replacement is something which is done for end-stage arthritis. People have a lot of arthritis, and it's affecting their quality of life. To me, that's the most important thing. So you put up an X-ray, and patients come in and say, do I need a knee replacement? I always tell people, nobody needs a knee replacement. At some point, you decide you want a knee replacement. It's a quality of life issue. I'm having pain. I've tried simple things, exercises, activity modification, potentially injection or medication. It's not improving. It's affecting my quality of life. What can you do to help me get better? We can do a knee replacement. And when you do a knee replacement, you cut out the arthritis. You're actually reshaping the bone. So you're actually making cuts to cut all the cartilage out and replacing that with metal on the femur side and typically a metal plate with plastic or ultra-high molecular weight polyethylene on the tibial side. So you're articulating now metal and plastic. It works great, but it's surgery. And again, there's no going back. You can't say, I wish I didn't do my knee replacement. I want to take it out and have my normal knee back. No, once it's done, it's done.
How long does it last?
Well, I think majority of them last long. So I tell patients the success rate of the nothing's 100%. The success rate of the surgery is probably about 90%. 90% of people will say, I'm improved. I would probably do the surgery again. But 10% of people say, no, I wish I didn't have the surgery done. It's not as good as I want it to be. So it's not, nothing's 100%. The failure rate where the prosthesis can wear out over time is, we used to say 1% per year. It's probably lower than that. So if you forget about those 10% of people who are just not happy, they had other issues, their knee didn't work out. The infection rate when you do a joint replacement is about 1%. That's devastating. You're putting an implant in, if it gets infected, or if you have to take it out and redo it again. 1% of the time. It's a real number. It's not common, but it happens. And then mechanically, it can wear down. Probably at 20 years, about 10% of them maybe have worn out. The other 90% are doing fine.
So about how long? About 10 years? You said 20
No,
years?
at 20 years.
Oh,
20 years, 10% have worn out.
Okay.
So the majority of them are doing well long term.
When you talk about infection rates, people want to go to different institutions, and I know, I'm sure, I don't know if the public has ever seen any of these surgical suites. It almost looks like you're going to outer space. Yeah. Because of the concern for infection, and everyone's not just gowned up with a mask. This is as outer space hazmat as you could ever be. Yes. So maybe just describe that and what they do, what we do in order to try to prevent infection.
Yeah. So when we're doing, we don't do it for all. When we're doing joint replacements, procedures that have a high infection rate, we're often wearing like a hood that brings the air on the. So there's no breathing on the field at all. So when you do surgery, we always wear a mask. So you're not directly breathing, but you still have the air coming out from around them. When you're doing a joint replacement, you're wearing a hood often there's a laminar flow to kind of keep the air circulating just within the surgical field. So it's not when people opening and closing the door outside the operating room, you're not bringing that air from the hallway in. Or at a minimum, you're keeping that door closed the whole time and limiting the amount of movement in and out of the operating room. All the operating rooms now are built to have a certain amount of flow to bring the air, to recirculate the air and clean the air. It's in general across it. But when you do a joint replacement, we often take extra precaution. We're giving antibiotic beforehand. But I think despite our best efforts, the infection rate's about 1%.
Are there better places? I mean, if say a patient comes to you,
Yeah.
or so many other orthopedists, whether in Manhattan, Brooklyn,
Yeah.
wherever, New Jersey, should they ask what their rates are? Is that
It
something?
can't hurt to ask, but I don't know if it's necessarily based upon like, oh, you have a higher infection rate in Brooklyn than in Manhattan, or in Long Island more than Staten Island. But I think you can see discrepancies within certain institutions, and even so they're at the point now. Even hospitals, they'll look and say, we have a higher infection rate in this room. They're following that. Like for some reason, when procedures that are done in room 6, we see more infections, and they try to investigate why. Is it maybe the flow different? And so I've seen that in hospitals where they're putting extra ventilation in a certain room because they saw that higher infection rate. But unfortunately, that's not information that we as surgeons have available to even us initially. That's something that the hospital looking at as just overall quality control over time. But I think most hospitals will do publish their overall infection rates. And clearly, some are better than others.
Let's jump out to the hip. So tell us about hips and what could happen with the hips and what do you have to do? Because the knee, much more commonly.
Yes.
Hip a lot of times, but a hip is either it's really, really bad or it's not.
Well, so that was always traditionally the case. So the hip is a ball and socket joint. You see hip fractures generally in middle-aged to older patients. Devastating injury needs surgery. We're maybe not talking about that today, but we are seeing hip arthritis. Where we talk about hip replacements. Let's talk on the sports medicine side where you hear about athletes. We're talking more about what we call impingement in the hip, like we talked about in the shoulder. Like the hip and shoulder are similar type joints, ball and socket. Just like you get impingement in the shoulder, you can get impingement in the hip. In certain positions, the hip comes up and there's contact between the labrum in the hip, which just like you have a labrum in the shoulder, and the edge of the femoral neck, and that can cause pain. And you see athletes who come in with hip pain, and they'll be treated. We'll evaluate them, often do MRI, or sometimes MRI even with dye to see if there's a tear in the labrum. And if you see that, a lot of those can get better with therapy and inflammation. If it doesn't, the options are to go in surgically and repair that labrum, similar to what we do in the shoulder. Where you go in and repair a labrum and a person has instability. They're doing that now with the hopes of potentially preventing, because we know development of arthritis down the road. We know people who have this impingement, that constant repetitive movement can actually shear off the cartilage in the hip and go on to form arthritis later down the road.
So what is arthritis? Maybe that's a good thing.
So arthritis is wearing down of articular cartilage. So on the end of each of our bones is amazing material called articular cartilage. It has a very, very low coefficient of friction. So it's super smooth and glides against the cartilage on the other side of the joint, perfectly well. So there's no strain or stress on the movement. With arthritis, that cartilage breaks down and starts to lose some of its smoothness. And then you can actually, some of that's microscopic. Then sometimes visibly, you can actually see it wearing down. It gets fibrillated and thinned, and then it can wear down to bone. So that's a whole process or progression of arthritis. When you have bone on bone, that's advanced arthritis. And that's when you start talking about doing hip replacement. So if someone has a labral tear and has significant arthritis in their hip, you can't just go in there and fix the labrum. Just like a person has advanced arthritis in their knee and has a meniscus tear, if you go in there and just clean up the meniscus, it doesn't fix their arthritis. So they often have residual pain. If you have a slight bit of cartilage wear and you have a labral tear that's causing mechanical symptoms, catching in the hip, sometimes you can go in there and clean that and repair that and provide that person relief of pain for 4 or 5, maybe even 10 years. before they progress on to, their arthritis progresses to the point where they may need a hip replacement. So you may be able to put off doing a hip replacement. And then in younger patients, we're doing it with the hopes that it makes it less likely for them to get arthritis, 20, 30 years down the road.
Tell us about hip replacement. I mean, surgery for hips have become more commonplace. I think our producer asked you earlier, Helene mentioned, different kinds of microsurgeries or
Yes.
less invasive.
Minimally invasive, yes.
Minimally invasive surgery, anterior front approach, posterior approach.
Yes.
And the answer is yes to everything.
Yes.
So.
I mean, they're all out there. They all work in the right hands.
Right.
So I think from a surgeon's perspective, you do the surgery that you're best at doing. I think they all work. They all work well. There are certain advantages to each approach. So a hip replacement, what you're actually doing is essentially, we talk about the shoulder, like resurfacing the joint. In a replacement, you're putting a prosthesis that actually goes down the canal of the femur and has a ball on the top, and you're replacing the socket. We're also doing true what we call resurfacing, where you're not putting a prosthesis down the shaft, just putting a cup on the head, essentially, and a plastic cup on the acetabulum, and you're doing a resurfacing. That's a whole different discussion. But that too is another procedure that's out there, particularly in patients who want to stay, very active and need to have extreme range of motion of the hip, or potentially go back to running even. But so replacement, you're actually cutting out the joint surfaces, the cartilage, and replacing it with typically metal and plastic, ultra high molecular polyethylene. There are also some people using metal on metal prostheses. Has the advantage of maybe not breaking down like the polyethylene, but it can create some metal, debris, if you will, and that metal, those ions can go into the blood. And as of right now, we don't have any long-term results as to whether that can create long-term problems, but something that's being investigated. So it's not something that's done routinely, metal on metal. It's just the traditional hip replacement, metal on polyethylene. It's been around for a long time. It works great. Hip replacement patients are probably some of the most satisfied patients that I see. They get a replacement, a week, they're walking, they go, I wish I did it sooner. Most people regret not doing it sooner, not having it done. But it has risks. The most, like we said, just like any replacement, about a 1% chance of infection. One of the risks that's pretty much inherent just to like hip replacement is the prosthesis can dislocate, can come apart. Because the hip naturally is less inherently stable when the replacement type in. And that's where you brought up anterior, posterior. There may be some advantage to anterior approach because all the dislocations, or at least 90% plus, are posterior dislocations. So when you're cutting the posterior tissue through a posterior approach, a little bit more likely for it to come out the back. When you do an anterior approach, a little less likely. So that's one of the potential advantages that you have brought up before about an anterior approach. There may be less risk of dislocation, maybe less soft tissue dissection, so a quicker recovery.
So really, whatever your surgeon's comfortable with, and whatever, looking at your anatomy, man, woman, there's a lot of reasons that go into it.
Yeah.
There's no one procedure that's
absolutely. Long term, they work great.
We're coming to the end of our half hour, so we're going to talk about the ankle for a couple of minutes. Tell us about the ankle.
Yeah.
Everybody has a sprained ankle. Everybody takes a bad step.
Yes. Very common.
You see athletes, every basketball player. I don't know how when they come down, they don't hurt themselves to the point where they can't play, but.
Yes.
And, sometimes they're out for a couple of weeks. So tell us a little bit.
Yeah. So the ankle, so a sprain is an injury to a ligament, right? So the most common ligament to get injured in the ankle are the outer side, the lateral ligaments, the anterior talofibular ligament, calcaneofibular ligament, and when you roll your ankle into this inverted position like that, it stretches those ligaments, and you can get some tearing. And that the good news is that those ligaments can heal. So often if you catch it early enough, you put them in a boot or a brace, allow it to heal with functional treatment, and it can go on and return to play. There are different degrees, like any sprain. You can have a little stretch, a grade 1 sprain. You can have a more significant stretch, like a grade 2, where there's actually looseness to the ligament, or you have a complete tear of the ligament, a grade 3 sprain. Even those can heal in the ankle. So sprains people recover, but they can be mild in 1 week, but more severe sprains can take 6 weeks, 2 months even.
Well, when they call a high ankle sprain, what's the difference?
So that's where the tear extends up into what we call the syndesmosis. There's actually ligaments that run between the tibia and the fibula, the two bones, and when that ligament gets injured, that's a high sprain. Those will typically take longer to recover. And more severe high sprains there's been a trend, again, in athletes, sometimes doing surgery for those, to kind of putting a construct in to hold the two bones closer together so that ligament can heal quickly and get patients back to playing quicker. So Tua, when he played at Alabama, had a high sprain. He elected to have surgery so he can get back and continue playing in his season. And had his surgery done and was able to resume play in a few weeks. Probably would have taken longer. So it's not something that we routinely do. Most people don't need surgery for even a typical high sprain.
So tell me, so everybody at the gym, everyone's playing basketball, running after their kids, whatever it is, running to first base in your softball game. You take a bad step. When do you know when to call an orthopedist?
Yeah, good question. So I think the initial thing you want to do is kind of get off it, wrap it, get the swelling down, let the inflammation go down. Ice it maybe the first day or so, but not much beyond that. So there used to be ice. It's probably fallen out of favor. Ice. First 8 hours, 12 hours, maybe a day. After that, probably less helpful.
Do you go to heat afterwards?
Yeah, probably a heat after. Early motion is beneficial. Like keeping it in a cast. We in the old days we put a cast on. Now we use a boot to promote ambulation so people can walk quicker. But we want you to come out of that boot and start moving the ankle to allow functional range of motion so it doesn't stiffen. So early motion is also beneficial as opposed to casting it. Now, how do you know? It's hard to tell. So there's I think they're called the Ottawa rules. But for emergency room evaluation in Canada, they looked at a study. If you could touch on the fibula bone, and because it's always sensitive where the injury was. But it's hard for a patient to say, hey, does it hurt on the back? If you touch along the back of the fibula bone and it doesn't hurt, more likely you don't have a fracture. Because if it has a fracture, it'll go through and through. It's hard to tell someone over the phone to do that. Right. So I'll do that in the office. I can say once somebody comes to be in the office, I pretty much get an X-ray. It's simple. It's available. We talk about exposure radiation, but the amount of radiation you get exposure in like an ankle X-ray is quite minimal. I think it's on the order of 0.01 millisieverts, which is basically less than you get, probably about 1/10 of what you get, flying across the country in a international flight. So the amount of X-ray on an extremity X-ray is very small. So I think if you have an injury, I don't think you need to worry about getting too much X-ray exposure having a simple X-ray. So it's never a bad thing to have an X-ray, because sometimes you'll go and people will come a week, 2 weeks later and say, I wish I had come sooner because I have a little fracture there. But it's hard to tell people to run to the doctor every time. If you can't put weight on it, it's not recovering as quickly as you like, then that's when you should probably go get looked at.
I want to thank you. John, it's a quick half hour. We did all this stuff. Couldn't do more in grand rounds at the hospital. So for everyone, I want to say thank you to Dr. John Linsalata, teaching us about how to keep our joints well, some of the options that orthopedists are using, and really just hope everybody stays healthy, and especially now that the weather's getting better, just stay safe, don't take any bad steps, and do everything in moderation. Have a great night.